Okay, so what did you get for section 1? For number 1.
B.
Wait, what? It's a fill-in. There is no A, B, C, D.
Renan?
Oh, I thought someone said B.
No.
Okay.
I thought so
I was like,
too.
wait, what? Okay, so yes, which hormone is released when blood pressure drops and starts the RAS pathway? It is renin. Yes. Okay. What is number 2?
Aldosterone.
Aldosterone. In the RAS system, this is the hormone that promotes sodium and water retention. Number 3,
Potassium.
potassium. This is the electrolyte that we most closely monitor on loop diuretics. Number 4.
Acetazolamide. I'm sure I'm butchering that.
Oh, I mean, it wasn't that bad. Acetazolamide.
Acetazolamide.
Mm-hmm.
Oh, okay. Thank you.
And you're welcome. What type of, I mean, obviously we know it's a carbonic anhydrase inhibitor, but what does that mean? What is the classification?
The diuretic?
It's a diuretic, and it works by reducing pressure in the eyeball for glaucoma. And you're not supposed to use it for a very specific type of glaucoma. Anybody know it?
Close. Closure.
I didn't hear.
Is it closed angle glaucoma?
You tell me what was on our thing. Our PowerPoint.
Acute angle?
You're asking me with a question mark. I want you to tell me with definitive excitement.
It's used for acute angle, but it's not used for closed angle glaucoma.
Okay. So, not exactly. It's not open or closed.
Is it for chronic? Is that what you mean? Or for acute?
It's called chronic non-congestive angle
Yeah.
closure glaucoma.
Okay.
It is contraindicated.
Can you say that again?
It is called, I'm going to put it in the chat. Everybody can see it. Chronic non-congestive or chronic simple angle closure glaucoma. Okay. What is number 5?
Sodium, like replacement salts.
Sodium.
Well, because it has sodium in it, those replacement salts.
I need you to think about the
Or,
other.
I mean,
Wouldn't it be
the
like
Potassium?
It would
like
be
potassium rich?
It would be potassium. Spironolactone is a potassium sparing diuretic.
and I'm mixing my words up, but the salt replacements that people use when they're on low sodium diets, don't they have potassium in it? Sorry, I was saying.
Yes,
just mixing
ma'am.
things up.
No, I think that actually that's a very, very good point, and I'm glad you said that. So she's extremely correct. Salt replacements like Mrs. Dash have a high amount of potassium. So this is a very, very good patient education. I didn't realize that's where you were going with it, Tony. I'm sorry.
Sorry, I'm momming, so I was mixing my words up.
Oh, you're fine. You're fine. But I'm really glad that you made the point because I'm pretty sure I forgot to say that in class. So a patient that is watching their potassium does not want to use a salt substitute. Okay. Potassium rich foods and supplements, they need to be very careful because it is potassium sparing. Number 6.
Hyponatremia.
Hyponatremia. So we didn't talk about SIADH like we should have. So SIADH is syndrome of inappropriate antidiuretic hormone. And it is the opposite of diabetes insipidus. Okay. So diabetes insipidus is when you are just dumping liters upon liters upon liters of fluid all day. Okay. SIADH is the opposite. Okay. So
That's great.
SIADH, syndrome of inappropriate antidiuretic hormone, is a condition where the body produces excess antidiuretic hormone causing water retention and low blood sodium. Okay. So this occurs because of a head injury. Something is going wrong in your brain to excrete an excessive amount of ADH. Okay. So you could have a head injury, a stroke, a brain tumor can do this specifically. And I want you to write this down, and I'm going to post this because obviously not everybody is in here. So I am going to post this, and I'm recording. Specifically small cell lung cancer. Why? I don't know. I don't know the reason. It's above my pay grade, but I do know that it is very specific with SIADH that particularly small cell lung cancer can produce an excessive amount of ADH, causing you to have symptoms of SIADH. Okay. So your symptoms are going to include all of the symptoms from hyponatremia. So it's going to start out with like headache, nausea, muscle cramps, weakness. And then once your sodium gets lower, that's when your CNS stuff kicks in. So you're confused. You can't remember anything. Nurse Mike has a great short video. Helps draw little dudes with symptoms. Are we allowed to draw on the whiteboard before test? No, you cannot draw on your whiteboard before the test. As soon as you hit start, you can write whatever you want on your whiteboard. But until you hit start, you cannot do that. That's called brain dumping, and it is actually illegal to do on the NCLEX. So as soon as you hit start, you can write whatever you want. Okay. When the hyponatremia gets severe, then you have your confusion, memory problems, irritability, tremors, and then seizures. So seizure prophylaxis is huge when we're talking about hyponatremia, and eventually coma that can lead to death. Okay. So the treatment is usually a fluid restriction. We didn't talk about hypertonic saline, but hypertonic saline is 3% saline. So instead of like 0.9, 0.45, it is 3%. So it is a very high amount of sodium. Okay. This is important. 3% saline can only be given at 25 milliliters per hour for 4 hours at a time. 25 milliliters per hour for a maximum of 4 hours before that patient has to be reevaluated. Okay. I have seen some new evidence-based practice that they are doing some very interesting things with hypertonic saline that makes me extremely uncomfortable because 3% saline is an extremely dangerous thing to give your patient, causing really large shifts in fluid balance is extremely dangerous and can cause your patient to go into a coma and become brain dead. Hypernatremia can absolutely kill your patient. So it's a very, very, very critical type of fluid, and it is only prescribed by a nephrologist. So you have to be very, very careful. Okay. Other medications that you would give would be diuretics because you want the patient, this patient is going to be holding on to a lot of fluid. There's also something that I want you to understand about the hyponatremia. Why is the hyponatremia happening?
I think maybe because there's so much fluid, everything's diluted in the system.
Yes, ma'am. This is called
Yes, ma'am.
dilutional hyponatremia. Yes, 100% yes. Okay. So another reason why you would want to be careful, very careful with 3% saline is because when you start diuresing that patient and they start getting rid of that fluid, that dilution is going to decrease, causing their serum sodium to change. So that hyponatremia, the more fluid they get off of their body, that hyponatremia is going to correct a little bit because it's no longer diluted. Okay. Does that make sense? Okay. You want to make sure that you treat the underlying condition when we're talking about SIADH. Is it caused by the tumor? Can we do something about the tumor? Is it caused by a brain injury? Is it caused by, there was also other things. It says pneumonia, tuberculosis, positive pressure ventilation. So whatever the causative agent is, you want to make sure that that's getting treated, because if we don't treat, just like diabetes insipidus,
Hold
you
on.
you need to give fluid and you need to give electrolytes, but you need to stop the symptoms from happening. You need to stop the fluid from dumping out of their body as fast as they can possibly dump it out. Or no matter what you give them is just going to come right back out. So with SIADH, you need to correct the problem and treat the syndrome. Okay?
Mrs. Simmons, sorry,
Yeah.
I don't mean to interrupt you, but Ari wants to know if you can let her in.
Yes, thank you. Sorry, I was looking at the
Yeah,
chat.
no, you're okay. Thank you so much. Sorry to
Oh,
interrupt.
no, you're fine. You're fine. So I want to share, where is, I don't remember if I put something like a thingy on Brightspace about DI versus SIADH. Yes, I did.
Off subject, that ring is gorgeous.
Oh, thank you, girl. That's
is
my
nice.
upgrade. That's my upgrade. I love it.
It did a good job on the upgrade.
I designed it.
Really?
I
Where
did.
at?
Did. I found some lady on TikTok. No joke. Swear to God. I found some lady on TikTok. Okay. So let me share this. You guys do have this in your Brightspace, but let's just look at it together. Okay. So when we're talking about SIADH versus diabetes insipidus, I did put this on your key points. So I want you to make sure you are looking at this, okay? So too much ADH is going to cause you to retain fluid, okay? It gives you all the causes that we just talked about, and make sure you remember that small cell tumor, okay? Signs and symptoms, you're going to have low urinary output because you're retaining everything, okay? Your urine is going to be very concentrated because you're not putting a lot out. This is like I haven't peed in 12 hours and I finally go pee and it's like dark amber, like terrible looking, by the way. But it's because the urine is so concentrated, okay? Fluid volume overload, hypertension, weight gain without edema, tachycardia because your heart is working so hard to get that fluid to go throughout the body because there's just so much fluid, okay? Nausea, vomiting, hyponatremia. So remember, if you have hyponatremia, you need seizure precautions. Elevate the head of the bed because you don't want all of that pressure and edema going to the brain, causing increased intracranial pressure. Okay, so that's why we elevate the head of the bed. Restrict fluid intake. This patient is going to be on a fluid restriction. They're going to get loop diuretics and vasopressin antagonists. So if vasopressin and desmopressin are going to cause the loss of water, you want the opposite medication. Okay. There are two drugs. I don't know if I want you to know them. I think it's more important for me that you know about the hypertonic saline than it is for me to know, because there's an oral drug called tolvaptan, and then there's an IV drug called conivaptan. But that's not going to be on your exam. So when you look at SIADH versus diabetes insipidus, it is literally the exact opposite. And we talked about diabetes insipidus. So if we have the opposite, you're going to have high urinary output. And is your urine going to be diluted or concentrated?
Concentrated.
No,
Diluted.
diluted. You're going to have an insane amount of urine output with diabetes insipidus. Okay. And like I said in lecture, 7 to 20 liters of fluid a day that you're putting out. Okay.
So is both of them diluted? Okay, the ADH is concentrated, I think. Is that right?
So with diabetes insipidus, there's not enough ADH.
Yes.
With SIADH, there's too much ADH.
Yes, I mean the urine.
Oh, so with DI, you have so much urine that the urine is
Diluted.
diluted.
Okay.
Yeah.
Then the other one will be concentrated then.
Yes. SIADH, you have
Yes.
concentrated urine.
Yeah, so I thought you're still on there. So okay, thank you.
Oh, I'm sorry. No, I went to the other side.
Okay.
The low urine specific gravity, I want to talk about that for a second. Urine specific gravity is a lab that basically tells you how diluted or concentrated the urine is. Okay. So with diabetes insipidus, it is so diluted that the urine specific gravity is very low, meaning that the solutes that are within the urine, there's just so much fluid compared to the particles. Okay. So then with SIADH, it's the opposite, where you have a high urine specific gravity because everything is so concentrated. It's like having a tablespoon of water and a tablespoon of, I'm going to use salt, and putting them together. That is super, super, super thick and concentrated, right? That's your SIADH. Now with DI, I have a tablespoon of salt, but I have a gallon of water. Does that make sense? Okay. So make sure you're looking at these little things that I put on Brightspace, especially where it's comparing and contrasting the diseases, okay? No, I don't want you over there. I want you over here. Okay. So what number were we on? 7?
Yes, 7.
What was the answer to 7? Hormone ADH acts on which part of the nephron?
The distal tubule.
The collecting duct.
It's both. It's the distal convoluted tubule and the collecting duct. Okay. Number 8, which finding would alert the nurse to an adverse effect of furosemide?
Hypokalemia.
Huh?
Low calcium, high potassium.
What other terrible thing could happen from IV furosemide?
Potassium.
Not potassium.
Is it the
Ototoxicity.
toxicity?
Ototoxicity.
Yeah.
If you give it IV too fast, you can cause ototoxicity. Which condition results from too little ADH?
Diabetes insipidus.
Diabetes insipidus. And then 10, the nurse recognizes that the RAS activation ultimately leads to what? What is the point of it?
Increased BP,
Increased blood
Blood
pressure.
pressure and blood volume.
Yes, increased blood pressure and blood volume. Okay. All right, let's go to section 2. So when we're talking about promoting water reabsorption, what hormone does this?
ADH.
ADH, antidiuretic hormone. And which gland produces ADH?
Posterior pituitary.
Posterior.
Posterior pituitary. Okay, so the posterior pituitary gland releases ADH. That tells the kidneys to promote water reabsorption so that you hold on to more volume. Okay, the kidneys, when they have low blood pressure or perfusion, triggers what?
Renin.
Renin. This is the very first step of the RAS system, okay? Renin converts to what?
Angiotensinogen.
Angiotensinogen, which converts to angiotensin 1,
One.
and then converted to angiotensin 2 in the
Lungs.
In the
lungs.
lungs. Mhm.
Okay. Angiotensin 2 causes what to happen?
Vasoconstriction.
Vasoconstriction. That vasoconstriction raises the blood pressure and stimulates what to release?
Aldosterone.
Aldosterone.
Aldosterone. And what does aldosterone cause you to do?
Reabsorb the
sodium.
Sodium and water.
And water. Yes. Reabsorb sodium and water. Yes. Okay. Oh, well, that's the next one. Okay. Aldosterone reabsorbs sodium and water, excretes what?
Potassium.
Potassium. And that expands the blood volume. Okay. If this concept is overactive, what does it cause?
Hypertension.
And
Fluid overload.
yes. And then if it's underactive, it's the opposite, doing what?
Hypotension.
Dehydration.
And dehydration. Yes. So we have diuretics that counteract this system, the RAS system. So loop and thiazide diuretics, what do they block?
Sodium.
Sodium.
Sodium reabsorption. Water follows salt, and then that decreases the blood pressure. Okay, so you are losing water and salt. Okay, potassium sparing retains
Potassium.
Potassium.
It felt like a trick question, but it wasn't. Retains potassium, but reduces the fluid, so it's still diuresing, but it's holding on to the potassium. Okay, and then osmotic pulls water quickly, and it's only used for increased intracranial pressure. What is this medication called?
Mannitol.
Mannitol. And what is the contraindication for this drug? No, not bleeding.
Is it heart?
Say it again.
Is it heart failure?
Kind of.
What's it called? Oh shit! Shoot! Sorry, I almost cussed.
What's caused by left-sided heart failure?
Pulmonary edema.
No, pulmonary edema.
Pulmonary edema, pulmonary congestion, crackles in the lungs, any onset, any chronic or new acute onset of pulmonary congestion, edema, crackles is a contraindication to mannitol because it can exacerbate that problem. Okay? Very important to know. All right, section 3. RAS raises all
3.
Sodium and water.
So it's like they're like little things that you can like little quick things that you can remember. So the first one is that raises all salt. And by doing that, you increase the blood pressure, sodium, and water retention, right? Because water follows salt, then you have more volume. So for diuretics, loop equals lose potassium.
Everything.
Potassium. And then thiazides equal, this one's kind of stupid. Mild diuretic, because it is. It is a mild diuretic. And what is hydrochlorothiazide used for?
Blood pressure.
It is the first medication used. That and what else?
Beta blockers.
Beta blockers. Okay. K sparing keeps potassium.
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 Osmotic pulls fluid
Puts
fast.
water.
This is just asking what the medication is.
Mannitol.
And it's mannitol. Yes. The medication that we talked about that lowers the eye pressure, what is that called?
Acetazolamide.
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 And it is contraindicated in what?
Closure.
Chronic non-congestive angle closure glaucoma.
Thank you. Yes, ma'am. Okay. Our pituitary, the anterior is responsible for growth hormone, adrenocorticotropic hormone, thyroid stimulating hormone, luteinizing hormone, follicle stimulating hormone, and
Prolactin.
prolactin. Okay. The posterior has what?
ADH and oxytocin.
Oxytocin.
And are they made there?
No.
No. Or are they just stored there?
Just stored there.
They're stored there.
Okay. Too much ADH equals, we just talked about
Sharon ADH.
SIADH. So soggy SIADH. And too little ADH is
DI.
DI
Insipidus.
or dry. Low blood pressure triggers what hormone to release?
Renin.
Renin. ADH causes what retention?
Water.
Water. Aldosterone causes what retention?
Sodium.
Sodium.
Sodium. Loop diuretics were at risk for
Hypokalemia.
hypokalemia. And what happens when we're hypokalemic? What are we at risk for hypokalemia?
Arrhythmia.
Arrhythmias, dysrhythmias, and cardiac arrest. What do you need to make sure your patient is wearing?
Defibrillator.
No.
Heart monitor.
Heart monitor.
I mean, if they
Monitor.
need a defibrillator, then yeah. Heart monitor, yes. Yes. If you need a defibrillator, yes, absolutely. Please put it on. Okay. And then some mnemonics. The posterior equals what control? So this is like your posterior pituitary.
Pressure. Pressure
Hmm?
control. Pressure control.
No, water.
Water.
Because ADH lives in the posterior. So ADH controls the water. Okay. RAS raises pressure all around, or raises pressure around. Loop equals lose it all. Spironolactone equals save the potassium. Save it. And mannitol equals man, move water out fast. I don't know if I like that one. That one's kind of dumb.
Pull water out fast.
It says man, move water out fast. I think that's kind of silly.
Man, pull water.
Yeah, I have
Alright.
pulled water out fast. Man pulls
I
water
mean,
out.
Yeah, but like the thing that I don't really like about that one is that it doesn't specify anything about the brain. And I feel like a good mnemonic would have something about mannitol working in the like specifically in one area. Because if you read that, you're just like, oh yeah, mannitol is a diuretic. I can use it anywhere because it pulls water out fast, right? So I don't know. I feel like it doesn't really give you anything, but whatever. Okay, so let's see.
My daughter said man has a small brain.
Who has a small brain?
That's what my daughter said. She said, just remember, a man has a small brain.
Oh, there you go. That's funny. Okay. Talk to me about Synthroid. What is Synthroid?
It's for
Is it
hypothyroidism.
levothyroxine? Levothyroxine?
Levothyroxine, and it is used for the treatment of hypothyroidism. I heard someone
Thyroxine.
say. What happens if the dose is too high?
Confusions?
Hmm. So let's look at our symptoms of hyper versus hypothyroidism. Where is that? Okay. So if you are hypothyroid, you're going to have weight gain, dry skin, hair, nails. You're going to be constipated, cold, depressed. Everything is slow. Everything sucks. Okay? You have no energy. You're gaining weight. You don't know why. I mean, listen, most of us are women, right? Every time we go to the doctor's office and we've gained a couple pounds, they're like, let's check your thyroid. Let's check your thyroid, right? I couldn't tell you how many times I have had my thyroid checked. Okay? And it's because of we go in and we say we're tired. I can't lose weight. My hair is dry. My nails are breaking. I'm constipated, right? And instead of looking at anything else, they look at our thyroid. Okay. So when a patient has hypothyroidism and they take levothyroxine, and all of a sudden they are taking too much and their levels are too high, what is going to happen?
Hyperthyroidism.
They are going to have symptoms of
Insomnia.
hyperthyroidism. Okay. So this patient is going to be anxious. We can't sleep. We're losing weight like crazy, sweating. Your metabolism is through the roof. Okay. So hypothyroidism, this you feel like a slug. You're just a slug. Hyper, you could run a marathon. You're like, let's go. I don't need sleep. What, you sleep 2 hours? I'm fine. I don't need that. And your metabolic rate is so high. Okay.
I want that.
right? Except that's when you get like a goiter and stuff. Like that's good. What is a very important patient education aspect of levothyroxine?
You take it with empty stomach in the morning.
Amen, sister. You give this every morning on an empty stomach. This is a lifelong medication, especially if you have your thyroid removed. Okay. And you should never ever stop this medication abruptly. You should never stop any medication abruptly.
Kenny.
Okay. I'm going to put that picture on Bright. There you go. Just had it. Here it is. Okay, I just added that picture to Brightspace. Okay, so when we're talking about other treatments, when we talk about thyroid stuff, so when your patient has hyperthyroidism, we have drugs called methomazoles or PTU. The mnemonic is methimazole, and like meth is capitalized, and it says because they're hyper, like on meth, which I think is hilarious. Okay, so hyperthyroidism, we treat it with methimazole because they're hyper, like on meth. So say that to yourself tomorrow. This has a very specific adverse effect called agranulocytosis. This is when you have a decrease in white blood cells and it decreases your immune system. So if your patient experiences this, what are they at risk for?
Infection.
Infection. So if our patient all of a sudden gets sick, we probably want them to tell someone about that. Right? Okay. So then we have one more with hyperthyroidism. It's iodine. And iodine is essential to thyroid function. We have to have it, okay? This is why we have iodized salt. There's iodine, I'm pretty sure it's in our water, and they put it in all kinds of stuff, okay? And foods have iodine too. But this is why you see kids in like third world countries with like huge goiters. Goiters is like that big huge lump in the neck because it's like a enlarged thyroid. Okay? And it's because they're not getting enough iodine in their diet. And this is why it's put into our salt and we don't see this in the US. Okay? So iodine, it actually destroys the thyroid tissue. So too much iodine can be extremely toxic and can be used as a treatment to treat hyperthyroidism. Okay. And the mnemonic for this, it says iodine equals thyroid murder juice, which I feel like is really intense. But it murders the thyroid. And you would want to and make sure that you teach your patients to use a straw with it. So I told you guys I wanted you to look at the parathyroid chapter. And you were like, yeah, I'll do that. Did you do that? I think it was
Is it
chapter 30.
chapter
She said,
37?
no. Tamara, I see you laughing, girl. I know you didn't look at it.
I did not.
She said, I did not. Well, you're the brave one that has your camera on. I can't see anybody else. It's rude. I'm like, I gotta sit here. But hi, Stella. Oh, Cheyenne, there you are. Cheyenne did have her camera on a little bit ago. So did anybody look at chapter 37?
I did.
Not one human. Not
I
one of my
did.
36
I
humans. Oh,
did.
Stella did? Ah, Stella!
I'm not sure.
It. Okay, so,
It is thyroid and parathyroid. Mm.
it's all about thyroid and parathyroid. So, what is super, super, super important about the parathyroid and its relationship to calcium?
It tightly regulates the calcium.
Mm-hmm. I'm breastfeeding up. Well, you know what, Chelsea? Maybe you could educate some people. No, I'm just kidding. Yes. So the parathyroid has a very, very distinct relationship with calcium. Okay. If your patient has a thyroidectomy, okay, the parathyroid are these 4 little nodules. Okay. And if they are injured during a thyroidectomy, your patient can have what's called a thyroid storm or a calcium storm. Okay. And it is extremely dangerous. So, the parathyroid releases calcitrol, which controls your which controls your calcium. So after a thyroidectomy, if there's any question whether or not that they accidentally touched the parathyroid, that patient will either be admitted overnight so that they can do routine monitoring like Q2, Q4 calcium levels to make sure that their body is not flooded with calcium. Okay. Super important. And I want you to put a star next to that and I want you to look it up. Okay. Because it's very, very important. Biphosphonates, which is used for high calcium and is used for treatment for osteoporosis. Okay. There is a very important patient education for this that I want you to look into. I can't just give you all the answers, guys. I need you to meet me halfway. Okay?
Can you
So,
repeat what you just said? Because I was
I sure
traveling.
can. Biphosphonates. There is a very important nursing intervention and patient education with biphosphonates. Okay? We talked a lot about Cushing's versus Addison's. Okay? Make sure you know it. You know the difference between the two. The mnemonic for the Cushing's versus Addison's, it says Cushing's gives you cushions and Addison's makes you Sadison. I'm sorry, but I think that's kind of funny. Okay. Cushing's gives you cushions and Addison's makes you Sadison. We talked about somatotropin with growth hormone. Okay. And the patient education for it is important. The contraindications, the routine monitoring. Okay. Metformin. We talked about what to do if your patient needs a CT scan with contrast. Did we talk about the GLP-1s, the Ozempic and the tirzepatide and the adverse effects?
No.
No. Okay. We did talk about gastroparesis a little bit. I'm pretty sure I mentioned it. But another huge adverse effect of a GLP-1 is pancreatitis. Okay. So which is extremely painful, if you've ever had pancreatitis or have had a patient with pancreatitis, you know that that patient is in a lot of pain. They are constantly asking for pain meds. They can't eat, they can't sleep, they can't do anything. They're in so much pain. Okay. So acute pancreatitis causing a lot of pain. What would you, if a patient called you and said, "Oh my God, I'm having all this pain in my abdomen," what do you think you would tell them?
Can we tell them to hold the medication first?
So how often are these drugs given?
Aren't they weekly injections?
They're weekly
something like that.
injections. Okay. So I don't know what day they take their meds. And they're telling me they're in severe abdominal pain. What do I need to tell them?
Go to
I would tell them
hospital.
not to eat anything. Go to the
Go
hospital.
to the hospital. Go to the hospital. Okay. I told you that you better look at your ATI insulin peaks, onsets, and durations. I feel like we have a really good grasp on diuretics. Correct me if I'm wrong. What'd you say, Cheyenne?
Better than GLP-1.
Better than GLP-1s.
Let me fix my fucking thing. Hi. Jessica? Hi.
Yeah.
I'm just gonna say it. I'm gonna come out with it. I'm just gonna say it.
You say it, girl.
I'm confused.
Why? What are you confused about?
Why don't I'm not gonna say it because you're not about to yell at me.
Why don't you remember any of this? Chastity, that's a really good question. I don't know why you don't remember these things.
Listen, I don't remember talking about thyroid.
That makes
The
me
other
want
day.
to come to your house.
Well, I mean, you can come and hang out and help us, sister. What day did we talk about thyroid?
You better look at chapter 37 is all I'm saying.
Jessica. Oh my
I don't know
gosh.
what to tell you. I don't know what to tell you. Okay.
I'm sweating.
You better look at it, girl.
It looks like Chastity's about to cry real tears.
She just
Okay,
needs to be reminded.
I think it's a lot though. I think
It is
it's
a lot.
we have a lot in this class.
It is a
So
lot.
are we focusing on the small PowerPoints, or do we do that and then do the big one that you gave us? That probably where, because if some people are reading the whole, just the big one that you condensed for us,
Yeah.
but I think the other one is specifically treating individual stuff.
Yeah.
So maybe that way, I don't know.
So
So
I think that's a good question. So I think that the big one that I put together has really good graphics and it has really good comparison things. And is something, fix your face. Don't make me call Missy. That I think those big PowerPoints have really good graphics. And once you have a basis for the content, you can look at those graphics and use those to like understand it better. Okay. So when we're looking at, hold on. What just happened? Oh, get out of here. Oh. Oh my goodness. Where'd you guys go? There you are. Okay. So when we're looking at this, like this is a nice side by side between the stimulating hormones that are in the hypothalamus versus the ones that are stopping things from happening. Okay. And then, this is like a good depiction on the negative feedback system, right? So there's a stimulus, and then the master gland, the hypothalamus, tells somebody to do something. And then the pituitary does what the hypothalamus told them, and it sends out a signal, and a hormone gets secreted, and then it goes to that specific target, and then whatever the problem was gets restored. Okay. We talked about homeostasis so much and the goal of balancing. Okay. This is basically the same thing. This is looking at the drugs a little bit closer. So I don't think that the big ones are, I don't think that either one of them are bad. I think that the bigger ones are just going to help you kind of hone things in after you've more like understood what's actually happening. So understanding the growth hormone, why are we using somatotropin? Okay. What is it for? And then what do we need to teach? So that's a big one that like this is missing, is like my patient that's on a growth hormone, I need to tell that parent that that kid is going to be in pain. And I need to make sure that they're getting x-rays of their long bones to make sure that the epiphyses aren't closed, right? So there's, well, in here, that's the next slide. right? So there are really important things in both slides. These big ones were made by using all of the little ones and putting them together on Notebook LM. So everything that's in here is also in the original PowerPoints that are on there. Okay. This is a good side-by-side for desmopressin over here, the water saver for DI, and then water expeller, the tolvaptan. This is for SIADH. I like this slide a little bit. It tells you the anterior pituitary has that growth hormone, and somatotropin helps growth. Octreotide stops growth with acromegaly. I like that it says the posterior down here with desmopressin versus tolvaptan, but like you need to take it a step further when it comes to pharmacology. Like, what are we treating? How are we treating it? What is our instruction to the patient? What do we need to tell them to look out for? What do we need to educate? How do we evaluate? Okay. So this is a good depiction on Cushing's versus Addison's. So Cushing's, that round moon face, is caused by like excessive steroids, right? And then the adrenal insufficiency, you can kind of tell that the skin is bronzed. It looks bronzed. Remember we talked about that? I'm in a meeting. We talked about glucocorticoids, how they increase the your serum glucose. It increases the protein breakdown and decreases formation, which is not good. Immune suppression. So I just feel like you need to go a step further when you're looking at these. And that's why it's so important to look at your drug categories and to go into the drug classification and say, okay, what is this for? What does it do? What do I need to look out for? What do I need to teach? And how do I know if it works? I wanted to go on that level up RN and do some of these flashcards with you guys. Oh, there's a quiz. Okay, so let's do the cards. Wow, it really wants you to like fill all of this in. Ugh. Okay. Let me share this. I thought it was going to be different. Will this be posted today? Yes, yes. And it's short. This is a short video, so it'll be available for me to download like within the hour. So our sulfonylureas are anti-diabetics. Okay. So what is the indication? Gotta give me a little bit and then we can flip the card. Give me something.
Would it be hyperglycemia?
Hyper.
Yeah.
Wow. So sulfonylureas are for hyperglycemia. And what type of diabetes?
Type 2?
2. So it is for type 2 diabetes. Glipizide. Think of gleefully riding down a slide with blood sugars coming down. So it increases the release of insulin from the pancreas. You don't want to give this to a patient that has a sulfa allergy. Okay. And of course, it can cause hypoglycemia. Photosensitivity, that's where the sunscreen comes in. Okay. So you're more susceptible to sunburn and effects of the sun. And take 30 minutes before a meal. Meglutinides. I'm just going to flip it because I feel like that's going to be better. So meglutinides, we didn't look at these a lot because they're not common at all. They are for type 2 diabetes and they increase insulin release from the pancreas, just like the sulfonylureas. And these are 3 times a day. And you need to eat within 30 minutes of the dose. So with all of these, hypoglycemia is going to be your number 1 risk factor. Okay. Biguanides, this is your metformin. Okay, this is one of the most common anti-diabetic medications in the country, if not the world. Okay, so this is for type 2 diabetes. You want to make sure you're holding metformin prior to procedures requiring contrast dye for 48 hours after the procedure. Discontinue 48 hours prior to procedures in requiring NPO or contrast. So a good rule is at least 24 hours before and 24 hours after. Okay. And you want to monitor for signs of lactic acidosis because it can cause rhabdomyolysis. Okay. Big risk for rhabdo. We did not go over this. Why is this dark?
Is this on a test?
Is this a test?
On the test.
Our diabetes meds?
Yeah.
Oh yeah, of course. We went over diabetes. There was chapter 38. We talked a little bit about Archibos. It's not a very common medication. Hepatotoxicity is huge. GLP-1s, we talked about that today. A big risk for acute pancreatitis, cholecystitis, which is the inflammation of your gallbladder, slows gastric emptying. So you do not want to give this to a patient that has gastroparesis. Okay. It has an increased risk of thyroid cancer. That's important. We talked about glucagon. Glucagon increases our blood sugar, right? So it can be given sub-Q, IM, or IV. And it can be given as like an oral gel. And you want to make sure that the oral gel, it's not something that they swallow. It's literally something that you squirt in their mouth and it absorbs into that vascular gum tissue. So when it says the patient is unable to take oral glucose, I'm not telling you that they're swallowing it. Okay, this is for a patient that is like unconscious and most often given IM. And as soon as it is safe to swallow, they need to eat or drink simple carbohydrates. Thyroid hormones, we talked about levothyroxine. When the dose is too high, your patient's going to be symptomatic of hyperthyroidism. You want to take it on an empty stomach with a full glass of water before breakfast and requires lifelong treatment, super important. This is the PTU. We talked about methimazole and PTU. Okay, so these are both for hyperthyroidism. We talked about agranulocytosis. Whoop. If you take too much of it, it will induce hypothyroidism. Okay. We talked about iodine today. What did it call it? Called it murder juice. So radioactive iodine can be used, which can cause radiation sickness. Contact with others should be limited. You want to be very careful when patients are on iodine solutions, because it can cause the people around them to have issues. And when you have too much iodine, you can have a metallic taste in your mouth. Stomatitis is inflammation of the mouth. It's not, doesn't feel good. Yeah, growth hormone. We talked about stopping the treatment prior to the epiphyseal closure. Very important. Antidiuretic hormones. So diabetes insipidus with desmopressin and vasopressin. What is the normal output? And I'm not talking about what it says on the screen right now. What is the normal output for a normal human per hour? The minimum.
30
you say-
mLs?
Did you say
30.
50
30 mLs per hour.
hour? Well, there's something you said about 50 in the class.
50 per day is
Okay.
anuria.
Okay, what about the
Anuria.
400?
Yep. Anuria is 50 mLs of urine per day.
Okay,
And then oliguria is
400.
less than 400 mLs
Okay.
per day. Okay.
Okay.
Glucocorticoids. These are, of course, going to increase your blood pressure. Okay. It is going to suppress your immune system, decrease inflammation. So everything that goes on with that. Okay. You want to make sure that this patient does not have an acute active infection. It must be tapered Mineral corticoids. This is a treatment for Addison's disease because Addison's disease does not get enough ACTH. Know your signs and symptoms of Addison's and Cushing's. I'm not going to do the insulin one here because I want you guys to get those from your ATI book. So we talked about the cholinergics and that they can cause cholinergic effects, so the non-obstructive urinary retention. This causes contraction and emptying of the bladder. Actually, we didn't even talk about these ones. We talked about the anticholinergics. We didn't talk about these ones. I'm not testing you on this. We talked about the anticholinergic. There we go. This is what we talked about. We talked about oxybutynin, which is our most common anticholinergic for the bladder, for overactive bladder. So you need to watch out for those anticholinergic effects: the dry mouth, urinary retention, constipation, blurred vision, tachycardia. All of those anticholinergic effects we need to watch for in these medications. We talked about the pyridine, benazopyridine, which is you can get it over the counter, azo. So pyro, if you think about pyro like it's on fire, like you have burning pee, fire coming out with your pee, ow. And then the side effect, of course, is going to be that orange-red discoloration of the urine and other bodily fluids. And remember, we talked about the staining of contact lenses and how much that would like really pee someone off if they paid a bunch of money for their contacts and then all of a sudden they were stained orange. Loop diuretics. We talked about that is our most effective diuretic, causing rapid diuresis. We see hypokalemia, hyponatremia, hypotension, ototoxicity, especially if IV furosemide is pushed too fast. And then you want to make sure you're consuming potassium because it's dumping your potassium. Okay. Thiazides. This is for mainly hypertension. It can be used for edema and heart failure, but most of the time it's used for hypertension, hydrochlorothiazide. Your side effects are going to include dehydration, hypokalemia and hyponatremia. Also, you want to make sure you monitor for hypotension. Anything that's going to lower your blood pressure, you need to watch for hypotension, okay? And you want to make sure you're getting in potassium. Potassium sparing. So this blocks aldosterone. It helps with the retention of potassium. So you can have hyperkalemia. Amenorrhea, gynecomastia, impotence. Remember we talked about how if you see a younger person, 20s, 30s, that's on spironolactone, and if they don't have any of the indications like heart failure or hypertension, they're probably on it for acne. Okay? And if they are, then you need to know that it can mess with their hormones, which is why in women, it can cause them to stop having a period. In men, it can cause breast tissue to grow. It can cause a lack of an erection, which is what impotence is. Okay? You want to make sure you're monitoring those potassium levels. Avoid salt substitutes because they contain potassium. I think Tony said that about an hour ago. So remember that. Osmotic diuretics, this is your mannitol. Okay. The side effects, heart failure, pulmonary edema, which is why it is contraindicated if you have heart failure or pulmonary edema. Okay. And we weren't going to do that one. So it looks like I don't want to take a quiz on all of them. I just want to take a quiz on some of them. Oh, here we go. So the nurse educates the patient taking metformin to report nausea, fatigue, and muscle cramps to the provider due to the risk for which complication associated with metformin?
Lactic acidosis.
Lactic acidosis. Yes. A nurse is caring for a conscious diabetic patient experiencing hypoglycemia. Which of the following orders for management of hypoglycemia should the nurse question? Which one is wrong?
The milk.
The milk. Definitely the milk. Oh, what? See, even Jessica can be wrong. Okay, 4 ounces. Oh, because milk has a lot of carbs. Okay, 4 ounces of
Yeah, I
orange
thought that
juice,
was
8 ounces of milk, and glucose gel can all be given to a conscious patient to bring up blood sugar levels. Glucagon is not given orally. See? Even Jessica makes mistakes. I hate doing that. So, I did say it's most common IM. So, glucagon, if it can't be given orally, then that would be the one to question. I didn't realize 8 ounces of, I've never seen that 8 ounces of milk can be given for, because I just
Wouldn't we also
take too long.
question glucagon because it's hypoglycemia?
Glucagon would increase
Oh,
the
it's
blood
to
sugar.
increase the blood sugar, yeah.
Yeah, yeah. That's a good question. That's a really good question. I'm glad because it definitely corrected my previous. All right, a nurse is providing teaching to a patient and their parents on somatotropin. The parents ask how long this medication will be given to their child. What response should the nurse provide?
Is it the first one?
I think
Yeah.
so.
Yeah, A.
I agree. A nurse is providing education to a patient newly prescribed metformin. Which of the following findings should the nurse educate the patient to report to the prescribing provider?
The muscle pain?
That's what I would pick because of the rhabdo and the lactic acidosis. So, yeah.
I have an honest question.
Yeah.
When it comes to calling a provider, when you get a new, any type of new medicine, is there certain things you would call for and you wouldn't call for? Not talking about like a hypochondriac type of person, but I mean honestly, if I started taking this medication and all of a sudden I have insomnia, well, would I not call for that? Or because it has
So,
nothing to do with that medication?
right. It doesn't have, it's not
Okay.
it's not an adverse effect of the medication. So that's where the knowledge of the medication itself comes in handy. Which is why like when we were talking about it and I said, oh, I would pick muscle pain because of rhabdo, because of lactic acidosis, because lactic acidosis happens from muscle breakdown. It can happen from other things, but it can happen from the muscle breakdown. So if all of a sudden I was experiencing heat intolerance and that was an adverse effect of metformin, then yeah, I would probably want to do something about, like I would probably want to tell someone. But And then you have to remember, especially when we talk about which one is the most correct, right? Which one is going to hurt your patient the most? Which is going to be the lactic acidosis, would hurt the patient more than any of these. Does that make sense? Even if they all, nausea is absolutely an adverse effect of metformin. Now, if it was uncontrollable vomiting, like you literally couldn't stop vomiting and couldn't keep anything down, then that would probably take priority, right? So you just have to assess, what is your biggest problem? What is going to hurt my patient the most? Okay. The nurse is caring for a patient who is unconscious and has a blood glucose level of 24. Ooh, which medication should the nurse administer?
D5W.
Glucogen.
D5W is a big bag of fluid. It's dextrose 5% in water. Now, if that said D50, I would agree with you. I'm going to say glucagon.
A. Yeah.
Yeah.
I have a question and it is really stupid, but
It's
I
not.
struggled with the endocrine system.
Okay.
What is the difference in glucagon and oral glucose gel?
Very good question. And I'm glad you asked that because that's what tripped me up earlier. So glucagon is given sub-Q, IM, or IV only. And that I was thinking about oral glucose gel for that first question that we had. And that's why I didn't question the oral glucagon, because they're not the same thing. The oral glucose gel, I don't know what it's called actually. I thought it was called glucagon, but apparently I am wrong. I'm gonna look it up.
And are glucose tabs ever like an option? You know how some people carry those glucose tabs around, or is that one of these meds?
So no, so this is what it says. It says oral glucose gel, which can be called Insta Glucose Gel, Glutose 15, or Dex 4, is a fast-acting 40% dextrose-based treatment designed for rapid reversal of hypoglycemia. It provides 15 to 24 grams of fast-acting carbohydrates to treat symptoms like dizziness, shaking, or confusion, typically acting within minutes. It says specifically, do not use if unconscious. So make this a rule. Don't ever put anything in someone's mouth when they're not conscious unless it's an intubation tube or suction. Okay? So when it comes to medication, if your patient is unconscious, do not put anything in their mouth. So glucagon specifically can be given sub-Q, IV, IM. And then oral glucose gel or tabs, your patient has to be conscious. Okay. A patient taking a strong iodine solution for hyperthyroidism reports a metallic taste, burning in the mouth, painful sores. Which complication should the nurse suspect? This is a good question. This is a really good question. No,
I think it's A. But
iodism.
then
It's
I
iodism.
agree. Okay.
These are the symptoms of iodine toxicity.
Okay. But I thought iodine toxicity is for the goiter.
So, well, you're thinking, right? But we're in this question, it was specifically asking about the iodine treatment for hyperthyroidism.
Okay.
Because it can like stop or slow the function of the thyroid. and it's
Okay.
toxic to the thyroid. A
The
patient,
goiter is for somebody that has a lack of iodine, right?
Yeah.
yes, because the thyroid gland is hypertrophied because it's working so hard to try to correct and maintain homeostasis that the gland just gets bigger and bigger and bigger because it's working so hard. But it doesn't matter because it's not working efficiently. That makes sense? A patient is beginning levothyroxine therapy for hypothyroidism. Which patient statement shows correct understanding of the teaching?
A.
A.
I agree. I didn't read the other ones. I will only be on the no. I will stop taking this medication too. No. I should expect to feel my heart racing. Well, you shouldn't because that's a bad adverse effect. If you feel your heart racing like tachycardia, that means you may be hyperthyroidism because you took too much. Patient has an order for levothyroxine 75 micrograms PO once daily. It is available in 25 microgram tablets. How many tablets?
3.
3. I gotta end this soon. The nurse educates a patient with Graves' disease. We didn't talk about Graves' disease. Graves' disease has to do with, oh my God, is it hypo? I think it's hypothyroidism. I just want to make sure before, I don't want to tell you something.
Is that the one that makes like their eyeballs almost like
Yes.
bulge?
Dude, my mom had Graves' disease, and this is actually kind of funny. When I was little, like, and before she found out she had Graves' disease, like when she would get mad, like her eyes legit would like pop out of her head. And we would get like really scared because it looked like they were like, I'm not kidding, they were like bulging out of her face. And it was scary. It was really scary. And when she got mad, it got even worse. But then she got diagnosed with Graves' disease. And so anyways, Graves' disease is an autoimmune disorder where the immune system attacks the thyroid, causing it to overproduce hormones, causing hyperthyroidism. Okay. So what of these drugs that are listed is used to treat hyperthyroidism? Because there's only one on this list. Every other one is for hypothyroidism.
I'm stuck between A and C.
Okay, that's a good place to be stuck in between.
The first one.
I'm gonna say
I
A.
I think A. Yeah.
This drug is normally referred to as PTU,
PTU.
prosthyuracil. It's called PTU because people don't like to say the name. A nurse monitors a patient receiving levothyroxine. Which symptoms should the nurse identify as being consistent with levothyroxine toxicity? Select all that apply. This is also a very good question.
Is it weight loss, tachycardia?
Okay, tachycardia, weight loss.
Yes.
Now we have both heat and cold intolerance. So that's telling me, even if I don't know, I know it's got to be one of them. It's got to be one of them.
It's cold.
You think? Does everybody agree? Okay.
This is for, never mind.
No, you're okay. So your patient's taking Synthroid because they have hypothyroidism, right? If you take
Yes.
too much Synthroid, it's going to cause you to have symptoms of
Hyper.
hyperthyroidism. So tachycardia and
Oh
weight
yeah.
loss. Our
If
symptoms,
that's,
go ahead.
go ahead. No.
Tachycardia and weight loss are symptoms of
Hyper.
hyperthyroidism. It is cold or heat intolerance a side effect of hyperthyroidism? Which
I
one?
think it's heat. Heat.
I
So
think it's
we're
heat
switching it
too.
up.
I'm switching to heat. Yeah.
All right. And that is
Yes.
correct. Yay.
Yes.
Good. So did that help though? Because that is a very good question. Like being able to understand that you're treating for hypothyroidism, but you're treating it too good, and then they're going over to the other side of hyper and then
Yeah.
experiencing those symptoms. So I need you to be able to distinguish that. That's a very, very good question. An unconscious patient with type 1 diabetes has a blood glucose level of 24. Which intervention should the nurse implement immediately? So first of all, we know we can't give anything oral because the patient is unconscious. Initiate an IV infusion of D5W. That's maintenance. That's not life-saving. That's maintenance. Begin an IV infusion of regular insulin. Obviously no. Okay. So
B.
that only leaves one, which would be
B.
our IM glucagon.
Mm-hmm.
Very good. A nurse is reviewing the plan for a patient with thyrotoxicosis. Which pharmacological interventions are appropriate? So thyroid toxicosis. Osis means a condition of toxic. Thyroid toxic. So it's a condition where the thyroid is toxic. Do you think that would be hypo or hyperthyroidism?
Hyper.
I agree. What drugs? First of all,
Yeah.
this is a select all that apply, right? What is vancomycin?
Bacteria.
It's an
Antibiotics.
antibiotic. Azithromycin is an antibiotic.
Antibiotics.
What is propranolol?
Beta
The
blocker.
beta
Beta blocker. Yes. So we have two drugs left, levothyroxine and the PTU. We know that both of these drugs are used for the thyroid. One is for hypothyroidism and one is for hyperthyroidism. But it's a select all. So are they trying to trick us? Because it shouldn't
Yes.
just be one answer, right?
Mhm.
So,
So we just did the PTU for hyper. So
but
so
it's
we're
a
gonna
select all. In the so me thinking as a nursing instructor and thinking about NCLEX, if I gave a select all, there's never only going to be one answer. That's crazy.
Yeah.
I would just make it a multiple choice question because that's just setting you up for failure, right? Which is leading me to believe that it's both and there's a reason. And I'm interested to know the rationale.
Okay, can we say the osis is osis disease that they need to treat for bacteria? Then we can choose the PT and then maybe the antibiotics.
Maybe. Do you want to try that? We'll see what happens.
I don't know. Oh yeah, I think.
Oh, nice try. Okay. Thyrotoxicosis is a life-threatening condition caused by excessively high levels of thyroid hormones. Treatments include beta blockers,
Okay.
such as propranolol, because probably of the tachycardia that's occurring.
Okay.
And anti-thyroid medications such as PTU and a thyroidectomy. Levothyroxine is used to treat hypothyroidism. Azithromycin and vancomycin are not indicated. So the answers were PTU and propranolol for the tachycardia that's caused from the hyperthyroidism. That is also a really good question.
Why is the
Have to
beta
steal
blocker
some
the answer?
questions from here. What?
Why is the beta blocker the answer too?
Because of the tachycardia that's being caused by the hyperthyroidism.
Oh, it slows the heart down. Okay.
A patient newly diagnosed with hypothyroidism is prescribed levothyroxine. During discharge teaching, the patient asks how long will they need to take the medication? Which response by the nurse is the most appropriate?
For the rest of your life.
For the rest of
B.
your life,
You
baby.
say rest of your life. Mhm.
The rest of your days. I'm going to start my car. We're going to go as soon as we're done with these questions. Do you guys like this? Or do you want to stop and ask your own questions? Because we're going to jump off of here as soon as these are done. Because I got to go home to my baby. Are we enjoying these questions?
Yeah.
Okay. Because I don't want to do it if you don't feel like it's helping you. I do feel like I do like them, but I just want to make sure everybody feels this way. Okay. 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 When mixing insulins in the same syringe, which one should be withdrawn from the vial first? Yes, I'm absolutely posting this, Jamal. So remember, we talked about mixing insulins and we talked about the proper way of mixing insulins. Didn't I put
Clear
that?
before cloudy.
Yeah.
Okay.
But that is not there. It's only cloudy that is there. So that's
So it would be the shorter acting insulin first and then the heavier,
ah.
right?
You tell me. So when you mix insulin, is it shorter acting or rapid acting?
Are they not the same? Short and rapid?
They are not the same.
Oh.
They're
I
not.
thought you're not gonna mix. I know you can mix the longer one. I know you can mix that.
I'm gonna say shorter.
Shorter should be the clear, maybe.
All right, I'm going to share this beautiful picture with you. So, how to mix insulin? Air in the cloudy, air in the clear. Draw up the cloudy, or I'm sorry, draw up the clear and then draw up the cloudy. So cloudy, clear, clear, cloudy. Okay? So our clear insulin is going to be rapid acting or regular insulin is designed to quickly lower the blood sugar after meals. This is going to be your insulin aspart, your insulin lispro. Okay? So rapid acting and your short acting insulin are not the same. Okay?
Yeah.
So when you see, now it's confusing me. Now I need to see the answer.
The question said short acting or long acting, so it would be
Right.
long acting then.
You never, ever, ever mix long acting insulin.
Yeah.
That's a big no-no.
Yeah, that's what I thought. You never
So the
mix that.
answer would be the short acting one.
I'm going to pick it. Good.
Yeah.
So when mixing insulins in the same syringe, the clear insulin, which is your regular insulin, which is shorter acting, should be withdrawn from the vial first, followed by the cloudy, longer acting insulin. Hold on. My husband's texting me. Hold on. He's like, where are you? Okay. Which of the following is most likely to result in a patient experiencing an Addisonian crisis? So Addison's disease. an Addisonian crisis, which is different from the disease itself.
Would it be
Um,
stopping their floretocortis abruptly
Yes.
would
The
cause
last,
them to go into crisis?
yeah.
yes.
I feel like I agree.
And then yeah.
It is correct. Abrupt discontinuation of a steroid such as fludrocortisone may lead to an Addisonian crisis because with Addison's disease, we have a very decreased amount of ACTH, which is our steroid hormone, okay? And we need steroids to be able to live. We need that ACTH, okay? Because when we experience stress or trauma, we have that release of ACTH that helps stimulate our bodies to be able to fight or flight and survive. And if you don't have that, then you will have Addison's. Okay? A patient with diabetes insipidus may receive treatment with which of the following medications? Don't you dare give them insulin. Don't you do it. Don't you
The
do
last one. Last one.
it. She said poop. Diabetes insipidus is not diabetes mellitus. Two
No,
completely different
no. I said the
No, not
last
you,
one.
Stella.
The vasopressin. That's what
Yeah,
you give.
no, not you. It was in the comments.
Ah, okay.
Yeah. Patients with diabetes insipidus. I messed up, Stella. Patients with diabetes insipidus will have large
We're all
volumes
tired.
of dilute urine and may require vasopressin therapy for hemodynamic support. Okay. A patient who self-administers insulin should be taught to rotate injection sites to prevent which complications? This is something we never went over. But do I have LPNs in this group?
Is it the B or C?
LPNs anywhere that give insulin? Anybody give insulin?
It's high.
Okay. Why is it number one, Tony?
I'm just guessing because lipohypertrophy, you're gonna get like fat pads and like scar tissue, right, in the same place.
Yes. You ever see someone that has like a big, it doesn't even have to be big, but it's usually a bigger abdomen that has like these patches of like brown skin on their abdomen and it's like kind of hard? Watch me be completely wrong, by the way. I'll be
Is
wrong.
that like lipoma or something?
Here we go. It's lipohypertrophy because of the fat cells. Lipolipids, fat cells is a possible complication of insulin use, which can be avoided by rotating injection sites. This is when you inject again and again and again and again in the same place, and it causes those skin tissues or skin issues. Okay. A patient taking long-term prednisone for rheumatoid arthritis asks about over-the-counter pain medications. Which instruction should the nurse provide? This question is specifically asking about a contraindication for prednisone. If you are taking long-term prednisone, what also should you not take?
NSAIDs.
NSAIDs.
Should not take NSAIDs.
NSAIDs. So what is an NSAID?
Ibuprofen.
Ibuprofen and then naproxen.
Oh,
I
naproxen
would,
is an NSAID, so that makes me want to change my mind.
so I would think it's acetaminophen.
No, I thought it was aspirin. Was one of them too.
I thought it was
Well, it's
But this is
asking,
this
it's
is only
asking
one.
what you want to tell them. You
I
want,
think
you are want to give this education.
Maybe
I think
B.
it's acetaminophen.
Yeah, I think it's B.
I think it's acetaminophen too, because
You may take
Ibuprofen,
acetaminophen for pain. Okay.
so NSAIDs are contraindicated. So naproxen and ibuprofen are both NSAIDs. So
Okay.
either of those
C.
are appropriate. And then aspirin, prednisone is already decreasing inflammation. If you take aspirin every day, we don't know if that's contraindicated. We don't know if they're already on anticoagulants. We don't know what's going on there. So it has to be yes. Oh, and aspirin, duh. Aspirin was the original NSAID.
That's what I said.
Aspirin is also an NSAID.
Yeah.
So all three, naproxen, aspirin, and ibuprofen are all N. All right, which anti-diabetic medication should be withheld for 48 hours after the administration of contrast dye?
Metformin.
Metformin.
Yes, baby. Metformin. What?
Oh.
Oh, it's a select all.
Yes, we still have to send.
It didn't say select all. That is not fair. Okay, that is so not fair. It did not specifically say that it was a select all that apply. So we are correct. But apparently it's also glipizide. But metformin is 100% correct. Okay, that just really made me mad. Okay, last one. Fluid retention and edema are key adverse effects of which anti-diabetic medication? Ooh, I don't like this one. Fluid retention and edema are key adverse effects of which anti-diabetic medication? So we talked about glyburide, which is the sulfonylurea. The Archibos one. I feel like it's the Archibos one because that's the one that says it's contraindicated with heart failure, I think, but I don't remember. I wish I knew everything. I wish I had a bigger brain.
I agree with you.
You agree? All right, let's see if we're right. Ah, damn it.
No, Theodore.
Oh well.
That's okay.
I'm not going to be asking that question. But we only missed 4.
I hope I only miss 4 tomorrow.
I completely agree. Tony said I quit. Okay,
Okay.
questions before I log off because I gotta go meet my husband and my child at Costco apparently.
Okay. Do you know how many questions we are expecting, please?
At least I like to do at least for high 30s to low 40s.
Okay.
I like to be in the 40s because it gives you more room for error.
Okay. So, and are we expecting more medications or just some medication plus the guide? So I don't want us to spend so much time on these medications and it's not there. I'm just saying.
So remember, Stella, when it comes to pharmacology, we need to know the disease, how to treat the disease, what they're at risk for, what we're educating for, and how we evaluate all 5 things. And remember the zebras. Think about the things that I've said multiple times, the things that we've talked about today, the things that are on your key points. Okay? Pharmacology is supposed to be hard, and I'm sorry.
Can I say cardiology was so much easier?
Yeah, I think
I agree, but most people don't agree.
Oh, I disagree.
Yeah, most people
I
don't.
disagree.
no, like I think cardio was like more. We have everything we wanted to do, but this one is everywhere.
Yeah, I
Like, it's
agree.
not.
I feel lost. I don't know where to start when it comes to studying.
So
We
I
have.
really think, and I was talking to somebody else earlier, that I do think flashcards are appropriate. I think a lot of people find flashcards very helpful when it comes to farm.
Mhm.
And a lot of the time, you want to look at the whole classification of drug and not just, you don't want
One.
to every single individual drug because that's just too much, right? Look at the classification. Look at what I've told you is the most common medications. Okay? And then most of the time, I don't need you to know that it's going to be nausea, vomiting, diarrhea, constipation, because that's every freaking medication there is in the world, right? GI effects is like every medication in the universe. But what is it that sticks out? What is it that's going to hurt your patient? What is it that I need to tell my patient that they need to know is going to happen to them? Okay. What can cause non-compliance? What do I need to look for to make sure that my patient is okay and doing well with that medication?
So if we cover your study guide, we are like 50% okay. Then we have to, because the medications are not like, why I'm emphasizing on this is I know many people are thinking about it but may not want to talk. I'm emphasizing because medications we went through today is not on the study guide. You know what I
Because
mean?
I
So
can't give you everything, Miss Stella.
I know, but I just
And you have to remember too, the reason that I did this, that we're sitting here right now, not that I don't normally do this because I do love doing this. It's usually at like 7 o'clock on a Wednesday night that I usually do this.
yeah.
But the reason that I'm doing this right now is because I was so off my game last week and there are so many things that I forgot. And if I didn't do this right now, you would have been completely unprepared for tomorrow and I would have felt so guilty. I would not be able to live with myself. I wouldn't,
That,
because it's not fair to you that, I mean, obviously we all understand my mom died. Like it is what it is. But at the
yeah.
same time, my mom dying is not an excuse for you to fail your test. Right?
Yeah.
So I can be sad and I can do all the things, but I also need to show up for you. Okay? And that's why we're doing this right now. And that's why I'm going to post this so you can rewatch it later and take notes. So,
Yeah.
because I did you a disservice last week. And is it understandable? Of course it is. But can I live with it? No. No, I can't. I sure can't. And this week is going to be better. I promise you that.
Thank you.
Damn, Jess, you done made me cry.
Girl,
I know.
I done
Thank
ran
you.
out of tears. Okay. But yeah, Tony, I agree with you. Put your guide and lectures into Google Notebook LM and ask it to put, yes, I love Notebook LM. Notebook LM is my bestie. I love it. Use it.
It
Okay.
takes time for me. I don't know why it never good for me. It takes forever.
Well,
I can
maybe
email you,
somebody
Stella.
can share their link with
Is
you.
yes.
Okay.
All
All right,
right.
guys, let me go because I'm gonna go meet my husband and my son at Costco. And as soon as this is ready, I will. You're very welcome. I will post this as soon as I promise you, it will be up tonight. Now, I might try to just send the video in an email because that's how I used to do it, and it was fine. I didn't start doing the whole YouTube thing until later on when people started complaining about it. Because it's really hard to upload the video if it's not on YouTube to like Notebook LM. So I'll send it in a Gmail and I'll also upload it to YouTube. But the thing with YouTube is that it takes forever. Okay. So I want it, the fastest way for me to get it to you is to send it through email. But be forewarned, it's going to be really hard to upload it to Notebook LM if it's not on YouTube yet. Okay?
Thank
All right.
you.
Thank you. Thank
All
you
right,
so
guys.
much.
Good
Thank
luck
you.
tomorrow.
Thank you.
I hope that I've made up for my shortcomings and this week will be much, much better. Okay?
Thank you.
Okay. Bye.
Bye.